Again. Again, I would like to just take a moment to introduce myself. My name is Deborah Levine. I am the director of the Harlem Health Initiative for the City University Graduate School of Public Health and Health Policy. I'm joined today by our investigators and support as a part of the Harlem Strong Initiative. You'll hear today from Dr. Victoria No, Dr. Malcolm Punter, and Dr. Susan Bean, along with some of our team members who will also be participating by following the chat. Please, if at any time you have any questions, please feel free to drop them in the chat. We have team members who will be following along and happy to stop us at any time to share that information. Next slide. So just for disclosure purposes, our Harlem Strong Initiative is being funded by the City University Interdisciplinary Research Grant, IRG 2841, the NIH Transformational Research to Address Health Disparities and Advance Health Equity Initiative, along with the Robert Wood Johnson Foundation Systems for Action, S4A, Robert Wood Johnson 79174. We're very grateful to our funders for their continued support, but most of all, I would really like to acknowledge the support of Healthfirst and Dr. Bean and her team, along with also all of the faculty and students from the Graduate School of Public Health and Health Policy, who have supported this initiative, even when it was just the beginning of a thought. But most of all, acknowledging our community partner, Dr. Malcolm Punter, and the Harlem Congregations for Community Improvement team. Next slide, please. So you heard me mention, we have been very fortunate. This is a very unique situation to have a coalition of this sort with these sorts of institutions where you have Healthfirst, a managed care institution, Harlem Congregations for Community Improvement, a community-based organization, a community development corporation with over 35 years of history in the community, along with the Center for Innovation in Mental Health. What I will tell you is that by trade, I'm a psychiatric social worker, and so mental health for me has been very, very critical in the work that I've done. When COVID hit in 2020, I happened to have been having some conversations with Dr. Punter about some of the concerns, not only that he was seeing in the community in terms of anxiety and depression in the constituents that we serve, but also in the staff who were delivering the services. Not knowing what from day to day, how we were going to sort of transition from doing direct service to now thinking about having to do things like meeting clients in the parks or being able to engage people through technology. But most of all, I think what became really clear was the sort of piling on of multiple losses, of not being sure whether or not tomorrow you were going to get another call about someone being impacted by COVID, on top of all the other social and racial inequities that communities like Harlem were already facing and being impacted with. I brought that conversation back to Dr. No and also to Dr. Bean through her being gracious enough to also sit as a CAB member for our dean, and talked about the concerns that Dr. Punter had raised about the residents of Harlem and the staff. And immediately, both of them said, tell us how we can help. Let's think about strategies that not only look at ways to support community residents, but how do we support our providers? How do we work with our community health workers? How do we utilize the school's resources to support the needs of the community? One thing that you will learn about the School of Public Health and Health Policy, we're located right on 125th Street. Our dean has charged us to ensure that the work that we continue to do is always centered in community. So one of the things that he agreed to immediately was to think about how do we use not only the data that the school was collecting, but how do we use our collective resources to support and find ways to bring, I guess, more conversation to the table around centering community and about the needs around mental health. Next slide. So as we continue to talk, we reached out to some of our partners that you see here on the page, and I am extremely proud to say that we have everyone from the Manhattan Borough President's Office to members of Harlem Hospital to the National Black Leadership Commission on Health, our partners at the Hope Center and others, and Orion Health, Harlem Pride, all came together at this call to talk about the concerns that we saw in the community. And this is the beginning of what has been probably some of the most groundbreaking work that I've seen around mental health in Harlem. This is just a sampling of some of the partners. As we continue to grow, we're looking for more partners to come. We have faith leaders that are a part of this work because they are a critical part of the pulse of the Harlem community. We also are working closely with not only the mayor's office, but also the Department of Health, because we really want this to be a continuum of care that doesn't just look at the consumer, but also supports the providers and those that stand in the middle in between. So this is just the beginning. I hope today will continue to pique your interest. We are again looking for more partners to be a part of this conversation. And I'm excited to turn the floor over to Dr. Punter. Next slide, please. Dr. Punter.
Thank you, Deborah, and thank you, Dr. Null and Dr. Bean, and all of you for assembling here. I hope you can hear me clearly.
Mm-hmm. Definitely.
So the Harlem Congregations for Community Improvement, as was summarized, is a coalition of faith-based organizations that initially started out in the Harlem community, but very rapidly in the early to late 1980s realized that the work that HCCI endeavored in revitalizing the housing stock in a community, an iconic community of Harlem, that same community that was understood to have gone through a renaissance of arts and culture, and had become sort of the centerpiece of the African American or Black community in the country, had become depressed physically in terms of its housing stock, but more importantly, that depression in housing stock resulted in real sort of clinical grade impacts on health, as well as mental health and other consequences. So the clergy, women and men of the Harlem community decided that they couldn't make much of an impact on their own. So they became a collaborative, something that was at the time novel in the community, because the community not only was experiencing disparate impacts in terms of health and economics, but the community had been quite separated in terms of its leadership. So the coalition came together, about 9 houses of worship at the time in 1986. They met in one of the Harlem communities, community spaces, the Minnesink Townhouse, which in and of itself had, was part of a coalition of the Mission Society, which had faith-based roots. So we decided to address the mental health issues in the Harlem community during the COVID crisis, something that we all were very surprised at in terms of lay people and community organizers and faith-based organizations. We hadn't really heard much about, this 100-year pandemic concept that, apparently affected us as a human community in the United States 100 years ago in the form of the Spanish flu. But, trying to address, what was occurring was very important to us as a community. One of the, sort of grim illustrations that we remember, too often regarding the pandemic of about 2.5 years ago was, the fact that many of our church-related and houses of worship-related funeral homes were overwhelmed. In fact, they couldn't even address, the rapid death and need for closure of families, and so much so that, you've seen the media depictions of box trucks outside of funeral homes. Many of our pastors and our clergy of all persuasions had, their stalwart parishioners or congregants, die wholesale and maybe even wiped out their leadership structure because of so many deaths during that time. As you can imagine, this colloquially, anecdotally, this was seen to be devastating and mental health consequences. So this coalition of ours with the School of Public Health decided to take a look at those issues. And we understood that there were already systemic disparities in the community. For example, the death rate was 2 times to 3 times higher for Black and Latinos in the community. Depression rates had increased 30 to 56%. But there were some real findings that we discovered after taking a sample of about 393 individuals. And we found that 42% of residents in the Harlem community, the greater Harlem community, had reported that they experienced a depression or increase in depression. Likewise, with anxiety. And one of the statistics that really shocked me was that people were equating their mental health risk with, concepts such as the post-traumatic stress disorder, a concept that we usually experience in terms of as it relates to the war and devastation impacts of war in communities, where people were feeling stress on that level, and as a congregate, that meant that mental health risks were increasing about 66%. And also there's been, and particularly in the Latino community, the Latino community in East Harlem felt disconnected from mental health care in a significant way. And in fact, we have reports that it was about 80%, 86% endorsed the fact that they were barriers to mental health care, which is a staggering result. Next slide, please. So we wanted to make sure that it is illustrative of, statistics is often hard to consume and studies are often difficult to understand. So we want to make sure the broad-based community understood this. So this illustration and this bar graph kind of shows, how impactful the barriers to mental health care have been, for the community, particularly the community of Harlem. 87% here, 86%, 87% rounded off indicates that people have barriers to mental health care. Likewise, the cost of mental health care is cost prohibitive for many. 28% of the people polled felt that way And again, this is in community districts 9, 10, and 11, which comprise of Central Harlem. Next slide. So, when we do formative statistics and formative research, we want to come up with some clear statements of needs. So we know that we have to improve mental health literacy. In order to do that, we want to, build the capacity in the community. And as a not-for-profit leader in the community, we know all too often that our staff, as well as the people, our consumers, don't get, mental health services really are non-existent for them. And so we struggled, to build the capacity to be able to provide that necessary resource. So, this particular initiative will help with the capacity building based on an evidence-based model that will help our caseworkers, our community, our health navigators, our social workers be in a better position to identify and refer our consumers to the services, as well as our management in our organization to be able to identify and refer, staff members to those services. And then we also want, thirdly, we also want our clergy to be able to identify and refer appropriately, because none of us are given mental health training in our respective fields of expertise. So we want to make sure we bridge that gap. We want to make sure funding is available. We want to strengthen and coordinate care across health, mental health, and social services. And we want the social determinants of health to be improved, and barriers to those health opportunities to be eliminated. So we think that we identified the problem appropriately. We know there's a limit to access to mental health services. We know the system is fragmented. We understand that in fragmentation, that's just not something that just happens on its own. That some of it is a key to that fragmentation is the legacy of structural racism in our country. We want to eliminate that, because we think that fundamentally, people would be improved, and maybe even the perception that undergird racism could be eliminated when we see everybody health and wellness consequences improve. We know that there's a lack of resources, and we want to motivate systems to invest in low-income minority communities in this way. So some of the three key solutions we believe, and then we hope to prove that during the course of our initiative, that communities that are partnered and culturally responsive, that have a social justice orientation and neighborhood focus, that they're going to improve, and we seek to establish this through the multi-sectoral planning and design and building a capacity for the various stakeholder groups that we identified. Community-wide collaborative care models, we believe it's going to be successful in addressing these disparities and inequities. And we're going to do that through an initiative, since HCCI having proved that a coalition of houses of worship have been successful over almost 4 decades. We believe that's the healthcare system, the community-based organizations, the houses of worship, primary care could also collaborate and be successful. So we're really replicating, in a sense, that model in Harlem Health Initiative. And then finally, we want to teach people to fish, right? So we want to make sure that they share the task of identifying and referring for mental health services, learning how to build that capacity, because we don't want to make them reliant on systems. We want them to be promoters and advocates and participants in the systems. Next slide. So that was a summary of what we found to be the issues and the problems, and we hope the methodology to address those issues. So we'll go on to the details of the study and overview.
Thank you, Dr. Punter. Hi, everyone. I'm Vicki No. I'm a director for the Center for Innovation and Mental Health, and we are so proud to be on this panel with such wonderful partners. Dr. Punter from HCCI has been an incredible leader in this effort. Dr. Bean, who has been so generous and gracious with all of the resources that Healthfirst has been able to bring to the table and is going to really help us make this effort more sustainable. And of course, the infamous Miss Deborah Levine, who's the glue that's, connects all of us and connects us to the community. We're so grateful for everything that you do. When we first started this project, I think one of the things that struck me is just not just the lack of resource, but the pain that we were experiencing in the community in the face of COVID. I spoke to an employment counselor last week about his referrals, for mental health services, and he had a client that was suicidal, and they have a partner who's a mental health partner working, in collaboration with them. And the earliest they could get this person in was 3 months to be seen by a therapist. And this is, a client who had suicide ideation, didn't have immediate suicide risk, but still that, it just blew my mind that with a situation like this, it still takes 3 months, and that's with a mental health partner already on board. So what we know is that we just don't have enough mental health providers. Many of the organizations that we've talked to have been struggling to hire mental health providers, especially in community-based organizations. And so, a really big motivation for Harlem Strong is really to build that capacity, support mental health task sharing, so that more folks who are already serving in a de facto counseling role, in a supportive role, can have the skills to be able to address mild to moderate levels of mental health issues, so that we don't contribute to this bottleneck, and we can address more things in the community. So, with that, our goals were to promote mental health awareness and access to resources across the community. We need to have, greater linkages to care through care navigation. The system is broken. It's fragmented. People make referrals and they just, get lost in the system. So that increasing that integration is going to be really important for the linkage to care. We want to be able to build capacity, mental health promotion, and task sharing skills. We also want to support continuous quality improvement. And what I mean by that is creating a community and a culture and organizations that are learning organizations and learning culture, so that we can constantly learn from what, from our experience and improve the system. And then, of course, strengthen community resilience. And in our vision is that we'll be able to close the care gaps and strengthen community mental health resilience in Harlem. Next slide, please. So our, grants have 3 aims. The first is to basically build the multi-sectoral coalition for mental health integration, which we're in the process of doing. Our second aim is to really tailor the intervention and the implementation plan to fit the community. And so that aim is really about working with the community to identify the barriers, the facilitators, the recommendations they have, so that our plans can be responsive to the community. And then our third aim is basically the implementation of the intervention. And what we're doing is implementing what we're calling a multi-sectoral collaborative care model in communities, and we're targeting low-income housing as well as primary care as 2 gateway sites that will be supported by a network of community organizations, faith-based organizations, mental health organizations, and we'll be evaluating that. So our collaborative network, in addition to all the wonderful partners that Deborah has already mentioned, we're also going to be inviting mental health and behavioral health sites so that they're part of the network, houses of worship, and community-based organizations that provide social services. And the idea here is that, if there's a collaborative network working together, we'll be able to facilitate that referral process and also facilitate that coordination of care across, all of these different service organizations that are, providing very important services. We also know that mental health, it doesn't exist in a bubble. Mental health issues are connected to health issues, connected to social issues, and need to be supported by a wide range of organizations. And so that will be the function of the collaborative network. So our process for making sure that our intervention and our implementation plan is responsive to the community is by doing a lot of community engaged planning. The first step of that is our community advisory board, which is made up of leaders and in the community from the system, from community-based organizations, and also resident leaders to help us make sure that we are doing right by the community. This is this is what we call our CAB, and we meet quarterly, and they'll be with us throughout the process so that anytime we encounter barriers in the system, we can bring it back to the CAB to help us problem solve those barriers. Our next activity that we use to support the planning of the intervention and the implementation is the Community Stakeholder Planning Council, and that consists of a wide range of consumers, leaders, providers, caregivers, and experts, and they gave us feedback on the barriers and facilitators. They essentially helped us co-design the intervention. We presented them with the intervention and the implementation plan, got feedback on that, as well as feedback and recommendations regarding the training content and then the training process. And we have just completed that. And so that is going to be informing our revision of the intervention and our plans. The third is the multi-stakeholder needs assessment, with which Dr. Punter already shared a little bit about. He shared about our resident surveys. So we did that. We're also completing our community leader surveys. We also conducted in-depth interviews with residents, CBO leaders, faith leaders, and staff to get their recommendations as well. And so it was a very comprehensive approach of spending about a year, getting feedback from the community before we launched the intervention. So let's talk about the intervention. So what is it that we're going to be promoting in the community? We're calling it the multi-sectoral collaborative care model, and collaborative care is essentially a team-based model of care that's primarily been used in primary care to integrate specialty care and into primary care settings. And in this case, we're integrating mental health task sharing into teams that will be implemented across the community. So in addition to primary care, we're integrating it into housing, and we'll also support its integration in community-based organizations. And we'll be working with navigators to support mental health promotion, screening and psychosocial assessment, psychoeducation to the community, as well as teaching navigators to deliver brief counseling that will be focused on stress management and wellness skills, as well as how to refer and create a coordinated care plan for their consumers. And we invite the community-based organizations, housing, primary care to include whoever may serve in a navigator role or those who might be able to support the screening or the outreach efforts. And so this might be different types of primary care providers, nurses, sometimes even physicians, are involved in that process as well, case managers, and those will be the folks that we enrolled in the program to receive training and technical support from us. So, one of the things that we know in the field is that we have a lot of really great evidence-based practices for depression and anxiety. We know how to treat it very well in research studies, but they actually don't roll out into the community. It takes about 17 years for an evidence-based practice to actually hit the community. So we are way behind. And one of the reasons for that is that there has not been enough focus on the strategies to move those interventions into the community. And so in this project, we're really focused on those strategies that support the intervention and that help move it into the community. In order for us to address the syndemics, of social risk, COVID-19 and mental health, we really need a comprehensive, multi-level, multi-sectoral approach that addresses, challenges at the organizational level. So in terms of that, we're building capacity at the organizations. At the community level, in terms of creating a coordinated system of care across the community, and at the larger societal system level, we really need, to be thinking about the structures that, that influence the community and the organizations. And, our CAB is meant to address that. We'll have the coalition, to support this effort. We'll have an electronic hub that will provide resources in the community. and offer hybrid training so that the training can be flexible. And what I mean by hybrid training is we'll have online training supported by webinars and in-person workshops as well. And we will also provide coaching and supervision to the navigators to support their implementation. We know that workshops by themselves don't work. That increases people's knowledge, but it doesn't necessarily change behaviors, provider behaviors, and help them adopt the practice in their setting. So ongoing coaching is really important for that. We will also have a learning collaborative to support all the implementers, and the learning collaborative will be utilizing a continuous quality improvement process. Well, they'll be looking at their metrics, problem solving, their barriers, and engaging in cross-site learning so that they can share their solutions with one another. And then we'll also support the data sharing that is needed for us to, share back the metrics, in terms of quality and outcomes in the community, as well as supporting the referral process. And we'll be supported as well with a client management tool. So what we want to know from our research is, what is the impact of an MCC program on increasing access to mental health services and improving consumer outcomes, including mental health, functioning, and social risks? We want to look at the added value of the coalition on access to care and consumer outcomes. We think that that's really important and critical for change to happen in the community. And so, we want to specifically focus on the impact of the coalition. We also want to look at the impact of the Harlem Strong Initiative on the providers and on the providers, knowledge, skills, as well as their adoption of mental health task sharing and the quality of the services that they provide. And lastly, we want to add in, we want to look at the integration of community identified technology solutions and determine how much added value that has for improving the implementation of mental health task sharing. Next slide. We're conducting a randomized control study, and actually as part of our community collaborative approach, we actually revise our design so that it's a step wedge cluster randomized control design. And what that means is it allows us to offer every single, each of the components to all of our partners that are involved in the project. It just didn't feel right to have some sites not get the coalition and the technology. And so that's the design we're going to use. And what we're doing is we're comparing 3 conditions. One is the education and resource, which is basically our online training on the mental health task sharing. So we'll train folks, but we don't think that's enough. So the second condition is the community engaged multi-sectoral collaborative care model, which is essentially the coalition and all the supports that come with the coalition. The third is a community crowdsourced technology solution, which we'll be implementing at a later stage to support implementation. So that's how we're going to assess the added value of the technology piece. But by the end of the grant period, all of sites will have access to all of the resources. Next slide, please. So here is just another depiction of the 3 conditions. You can see here what's different about them. The education and resource doesn't have that link across the organizations. We can train these organizations, but without the link, we don't think that's enough to really change the system. And so the MCC model is the one that has the navigator in the middle, linking all these organizations together. And then our third is the technology. And so that's essentially the MCC plus the technology. Next slide. So in terms of our research design, we're using a step wedge clustered randomized control study with supplementation to study the technology. We'll be enrolling 20 sites, about 100 providers who will serve at navigator roles and community provider roles. And then we'll have consumers, approximately 700. We will be conducting a hybrid implementation effectiveness study. What that means is that we're studying both the impact on outcomes and the impact on implementation, because we think it's really important to understand, the implementation of the program in order to know whether it's effective or not. And so we'll be looking at outcomes like depression and anxiety in terms of effectiveness on consumers. And then also we'll be evaluating the reach, which is an implementation outcome. How much are we touching everyone that needs to be touched, and how much are they getting the services that they need. We'll secondarily look at functioning, we'll look at well-being, we'll look at social risks, which include housing risk, housing insecurity, employment insecurity, food insecurity, and we'll look at the extent to which providers are adopting the services. We'll use a mixed methods approach. So we'll be, surveying providers, surveying consumers across the time frame of the project, over 2 years for providers and over 1 year for consumers. And we'll look at implementation data that will be collected from the sites in terms of what services they provide. And we'll also be interviewing the network as well as the consumers to understand their experience in engaging in this program. So this is a 5-year project, probably 6 years actually, but we are now closing out our developmental phase, and in February of next year we'll launch the coalition, and we'll start our project, and we'll have that going for the next 3 to 4 years, and we're really excited to get this going. And before we end, I want to hand it over to Dr. Bean, who will talk about sustainability and our plans around that and the importance of that.
Thank you so much, Dr. No. I too just want to express my excitement and I'm truly humbled by the opportunity to work with these amazing researchers. I have learned so much, and my team would say the same thing about how we can actually change the model of care for residents of Harlem, many of whom have chosen Healthfirst as a managed care plan. So what's key to our participation in this study as both an advisor and an active participant, hopefully an evaluator, is undergirding all of the opportunities that you've heard so far is funding, right? Ongoing funding. And we do know that managed care or insurance that's under the an accountability model, meaning that managed care means that there's someone looking over the shoulder of the company, making sure that quality outcomes are achieved. That managed care in New York State and then nationally becomes a really important consideration. From our perspective, Healthfirst serves about 1.8 million people in our region, many of whom do live in the village of Harlem and are served by us in a number of ways across a spectrum of health coverages. What frightens me most about the data that you saw in terms of baseline understanding of the needs of our community is the one that says that 86% of residents surveys stated that they faced barriers to accessing care. Now, you might say, well, just get them health insurance and that will solve it. But as Dr. Punter shared with us, only 14% reported that they did not have health insurance. So certainly we do want to get health insurance for all. That's an aim. But for the remainder of those who are facing barriers to access to care, this implementing testing and reporting out on this model becomes really, really critical. So from the Healthfirst perspective, we have a few roles that we hope to play. So we are first mobilizing our provider community in Harlem, getting them excited about this study, helping them to feel like Harlem can be strong. Many of them are discouraged. I mean, the pandemic was very, very hard on so many communities, and these dedicated essential workers often, were displaced, had family issues, suffered themselves, passed away themselves. So we definitely do have to support our providers, and we call that our SAP and the Helping You program. Those programs are all tools and resources that we are mobilizing to help our primary care providers and also providers who are specialists, including mental health. And the heartbeat of that is community navigation. We realize that the physicians and health professionals in provider clinics and offices are often frustrated because their reach is limited. And people live most of their life in the communities where they work, sleep at night, hopefully in homes, and have recreation. So community navigation, and have a spiritual life also. So community navigation is critical. And Healthfirst believes that the combination of primary care integrated with community-based organizations such as HCCI is the future of ensuring optimal outcomes for people across our service area, across our state, frankly, across our nation. And so where else but in Harlem should we test this? We are very, very dedicated to doing this in a rigorous fashion. You can see the kind of researchers we're working with. Dr. Punter, Dr. No, and Deborah demand that of us. We do want to rise to that occasion. But these lessons learned as we move through this process are going to be critical for making sure that funds flow to the mental health networks that support Harlem, and obviously the community navigators that are rising up to support Harlem, and also for the managed care and community health providers that support this community.
Thank you,
I pass it back to Deborah.
Thank you, Dr. Bean. Thank you, Dr. No, Dr. Punter. Now you see why we're super excited. This leadership mobilization model, this coalition, this multi-sector approach is everything that we know that needs to work. It's bringing all of the entities together so that we can make the change. And I think what's extraordinary about this is that it's about building capacity in our communities so that as institutions, whether the School of Public Health or Healthfirst or HCCI is no longer a part or in this existence, the coalition will have the skills and the support and the relationships to continue to move the agenda forward. So just a little bit about our next steps. And here's where we definitely want our community partners, the students, the faculty, associations, block associations, providers, to definitely help us as we continue to expand. We'll be launching the coalition in February of 2022. And we invite you all to come to the table and to bring others with you. They don't have to provide mental health services, but they have to have a desire to want to address the stigma and discrimination that's attached to issues around talking around mental health. So please think about who else can be at the table. We'll also be launching the Harlem Strong eHub, which we're super excited about. So for those that may not be able to attend in-person trainings or feel that they want to continue their education around mental health, have the opportunity to do this in a virtual environment. So that means that you can do it at night, you can do it at lunch, you can do it on your breaks, you can do it in teams. And we want to continue to engage and recruit gateway and coalition sites. So providers, if there are providers in the community that should be a part of these conversations, please send us your way so that we can engage them and bring them into the process. We know that we've shared a ton of information with you all. So if there are questions, please feel free to drop them in the chat, but also know that we will be doing a part 2 to this webinar series that will look at more of the data and the information. That'll be on December 7th at 1:30. We'll also be able to address any additional questions that you have about the work, because the goal here is for us to be transparent. we really, when we say we are centering this around community and our community partners, part of that means that we are working with our community boards, 9, 10, and 11, to continue to share what we've learned, not only from the focus groups, but the data collection. We have Dr. Flores here also with us, who is helping with the eHub and making sure that our eHub is easily used, is culturally competent, and sensitive to the needs of our community. So we're super excited and really looking forward to, actually, sorry, that should say February 2023. We are so stuck in 2022. But that is February 2023. And please feel free to reach out to us, any one of us, to ask questions or to support the process going forward. Next slide. So this ends our portion of the panel discussion. You see here, you have all of our email addresses, so please feel free to take them down. You'll also be getting a copy of the slide deck so that you don't have to memorize all that information or think that you may not have access to these emails. One of the staff members will also drop them into the chat so that you're able to access there. And what we will do is do a round robin of some questions that we've received earlier as we were doing registration. So, Claire?
Hi, good afternoon. I mean, good morning.
Let me introduce Claire Osborne, who is one of our Harlem Strong coordinators and also a recent graduate of the school. So we support our next set of public health leaders in this process, also in this work.
Good morning, everyone. It's great to have you here. I hope you've learned a lot this morning. I have, despite working on this project for a long time. I still learn new things each time. So we're just going to jump into some panel questions for Deborah, Dr. Bean, Dr. No, and Dr. Punter. And please, if you have questions to add, please put them in the chat and we'll do those too. So my first question is for Dr. Punter. I was hoping you could talk a little bit more about the navigators at HCCI, and I know they have different expertise and they have a level of trust in the community that will be important to this project. Could you just speak on that a little bit?
I think you're muted.
Okay, I'm sorry. I wasn't able to unmute myself. Thank you. As I mentioned, Harlem Congregation for Community Improvement has a deep root in the Harlem community. And because we're structured as a coalition of all the houses of worship, primarily in the Harlem community, over 100, we have a unique communication network. Every Sunday, every Saturday, every Friday, we technically can give a message to hundreds and thousands of people that live in the community, through our messengers. I think the Harlem Strong Initiative kind of utilizes that network in a way that's unique and that makes a positive contribution to the ability to train, increase awareness, navigate, and motivate, not only our leadership in the community, but also the people that they serve. Again, as the problem that we've seen in the Harlem community is that, pre-pandemic, there was already a lot of pressures in the Harlem community, right? The pressures of, gentrification, for example, displacement, there was gun violence, as a health consequence. All of those pressures still exist and existed pre-pandemic. When once the pandemic was placed on top of that, we saw so many different mental health consequences just increase. And as the formative research has shown us, people are willing to express it, and I'm very happy that they're willing to express it, because what I have been afraid of is that people have been so cloistered in the Harlem community for so long. Oftentimes we kind of make an amusing statement about across 110th Street, and many people cite in the early 80s and 90s. They get off the train on 96th Street on that 7th Avenue line. Everybody from 96th Street and below got off the train, and everybody else came up to Harlem. I lived that as a native Harlem resident, and that, while that may be spoken about as something that people look back to in terms of pre-gentrification as a source of pride, I argue that it was a source of systemic segregation. And because technically, when you crossed 110th Street at that time, garbage wasn't being picked up on a regular basis by the sanitation department. You knew that the only, possibly the only medical expertise that you could rely on is a gunshot wound, in an emergency medicine, right? There was no prenatal or other services to speak of. Likewise, we still have those barriers with mental health. And that's what we're really trying to combat here as association, as a coalition, and as a society. So many of those factors still exist because, while, changes have happened, changes on the surface may appear significant, but, those undercurrents and those cultural barriers and such, those are legacy matters that have to be addressed over time. So this is kind of what I think continues to be the problem in terms of the community. I think generationally we have to make some changes, but I think coalitions like this could make those impacts. And I think Dr. Noah had mentioned it, that interventions take significant time to make change.
Great. Thank you so much, Dr. Punter. I'll do the next question for Deborah. So Dr. Punter spoke on some of the, things we want to address in Harlem, as well as some of the strengths of the Harlem community. Can you talk about some of your community engagement efforts for this project, where you've drawn on those community strengths?
Sure thing. So what I would say to you immediately is looking at this from a leadership development sort of model. That this was, we saw what was happening in the community around depression and anxiety. We heard from the community constituents, but we also heard from the system leaders like Dr. Bean, and the providers who were struggling to figure out how to access communities so that services could be rendered. And also thinking about what Dr. No was talking about systemic racism in the community as another sort of barrier to this care. I think what makes the coalition unique and special is that it is looking at it from a systems perspective. It is this unique relationship that we are developing with Healthfirst. It's bringing in HCCI, a community development corporation with over 40 years of experience, that has not only faith leaders who are diverse, but are also skilled in not only talking about faith, but also has a history of talking about health disparities in the community. That is sort of the cornerstone of their work. When no one else would stand up and talk about things like diabetes and hypertension and HIV, it only makes sense that we arm them with the knowledge of how to identify anxiety and depression. That not only do we work with the faith communities, but we support the providers in being part of the fabric of the community and not just a provider in the community. And I think with organizations like Healthfirst being able to change the narrative about how providers engage community, how as a collective, they have responded not only to the needs of the community, but also the needs of their providers. And then working with an academic institution like the School of Public Health, where our dean doesn't use the term health disparities, but calls it what it is, social and racial inequities. So when you have that sort of leadership of both from the community, academic, our health institutions, we are in a perfect place along with our elected officials, because again, you can't talk about making systematic changes unless you include health policy as a part of that work. We really have this extraordinary opportunity not only to change the temperature in Harlem about mental health and getting people connected to care, but this is a model that can be used in other communities. This is a model that we hope to be able to share in other parts of New York City, other parts of the state, could be lifted up as a national model for ways that we collaborate, just not with pulling in providers, but really looking at it from a systems issue. So I hope that helps.
I think another thing that's really unique about our group and our partnership is that we represent the community. I think almost more than 90% of folks involved in this project come from ethnic minority communities, come from low-income communities. I myself am a refugee. I grew up poor through most of my life until I went to college, or actually through grad school. And I think, working with folks who have had the lived experience of struggling with the mental health system, struggling with some of the social issues that we're trying to address, brings another layer and perspective that I think can really change the system, because up until now, it was, administrators at the top making policy decisions and designing programs and implementing them. We're doing this at all levels, and everyone, including the leadership, are leaders who come from the community and who understand it personally. So it's a personal project. It's a personal commitment for many of us, and I think that is really unique.
Dr. Bean, you have to unmute.
Yes, and if I may build on what you're saying, Dr. No, we talked about words like comfort and trust, etc. But I think another word that I would add in terms of the vocabulary that this coalition uses is value. I think that part of the impact of racism, especially systemic racism, is depriving people of value, their sense of value. And the way that happens in my mind is, I need mental health, but 86% of people say I cannot access it. That's a value issue. That speaks to what do we consider our values. And I think that that's what's really driving many of my colleagues and me to really work hard on this project, because of the rich value that, not only New York City or New York State or this nation, the world has derived from Harlem. Value that is deep in the roots of who we are, yet we are not bringing back value in terms of making sure that, there are mental health resources readily accessible, and making it more comfortable and easier for providers to do that work, providers who are dedicated to this community because they see value here. So it's really value, and it talks to our values, to what we value, but more importantly, that the residents of Harlem can bring their own value to the table because, these organizations, these providers, are showing them the path to do that. And that also speaks to the navigation model, where you're not alone in this journey. There's someone next to you saying, "Excuse me, Susan asked for this, and she really needs it. Let's get that for her," so that, maybe Susan's not fighting alone. So I really love that word value, that people feel valued, and therefore they continue to add their value to the society and, to our culture.
Mhm.
Thank you, Dr. Bean. On that note, would you be able to speak a little bit about Healthfirst's organizational values and sort of how they overlap or maybe differ from, the values of this project?
Oh, absolutely. I mean, if I bring to this conversation my CEO, our executive leadership, my colleagues, many of whom are on this call, to demonstrate our commitment to this work. And that is because, we are a provider-sponsored company. We are sponsored by the voluntary hospitals, most of them of this region. They are dedicated to improving outcomes in the communities that they serve. They're not-for-profit as well. And more importantly, from our CEO, there's a statement around, around structural racism and the importance of addressing equity. So, I wouldn't, come to this table and be able to put forward resources in the way that, I hope is helpful if it were not for the support of my leadership and the whole organization. And I think we believe as a managed care plan that our colleague managed care plans will follow us. So our aim is not that Healthfirst is the only plan helping residents of Harlem and communities like that, but our vision is every health plan will find ways to step in and bring value to this discussion and to the providers and to the residents as well. I hope that answered it.
Yes, that's great. Thank you. And, we're really grateful to have Healthfirst on board, and definitely inspired by, the commitment of everyone on the project. And then, definitely to be able to influence other health plans as well is a great, aim. So thank you for that. I'd like to follow up with Dr. No. In the presentation, you spoke about the CAB and the CSPC, the Community Advisory Board and the Community Stakeholder Planning Council, which is where we're getting community feedback on our intervention. Can you just talk about some of the specific ways that we've, sort of edited the project to better suit community feedback and needs?
Sure. Thank you for that question, Claire. Well, first is we changed our research design. I think one of the things that we found early on is that it wouldn't be fair for some sites to not get to be part of the coalition. And so that's the first thing that we changed. Secondly, is that we have a much bigger focus now on provider self-care. We heard loud and clear that, those who are providing support need support themselves. We need to heal the healers. And so that has become a more central role in, central part of our intervention and our training. Another is that, there's a very wide range of needs that are in the community that are beyond just depression and anxiety for those who are, in your general adult population. And, we've heard a lot about, the need to address issues for, an older adults. We've heard the need to address issues for families and children. And so we are trying to find ways of incorporating that into the work of the coalition. We'll have coalition events where we can share and disseminate information and resources related to things that are outside of the immediate scope of our project, but that still, is able to support those who are serving these different communities. And so that's, those are some of the examples of things that we've modified.
And Dr. Ned, just as an extra point to that, what I would also say is that to thank our community residents who have been so gracious with their time and their expertise and their critique of the work, and really helping guide the process around engagement, letting us know historically what has worked and what hasn't worked, and also to raise issues around how communication should happen in the community, which has been extremely helpful and has helped us sort of adapt and tailor how we design information, how we share information, and I think has also been extremely beneficial for our system leaders to be able to hear from the voices of the boots on the ground. Not only just in HCCI housing, but we've also heard the voices from NYCHA housing and the concerns there. And we wouldn't have been able to do that without the trust of our community partners, and feeling like they could share not only the good, but the bad with us so that we could think about this from a holistic perspective.
Thank you, Deborah and Dr. Nove, for that. That's helpful to understand, more of the details about the community engagement piece of the project. I'd like to talk a little bit about, how we talk about mental health, since it can be a tough topic to talk about, or maybe it's stigmatized, or, we sometimes feel like we're not allowed to show our what might be perceived as a weakness or something. I'm wondering if maybe Dr. Punter or Dr. Bean can speak about, as far as the navigators or the providers at your organization, if you have noticed ways that they talk about mental health or sort of integrate it into other discussions so that it's easier to help people get help.
Dr. Punter, would you like to go first, or I'm glad to start and punt it to you? You're on mute.
I don't know. Well, I guess I'm not muted now, but thank you for that question, Claire, and that lead in, Dr. Bean. I think as a non-clinician, I think, I think that our staff focuses on the physical aspects. Those staff members that focus on health and wellness really are addressing a narrow condition. For example, HCCI has been operating a intensive case management services for people living with HIV and AIDS since the early 90s, right? And so over 30 years, we've had that program. We still have it. We provide housing for those families and individuals. And then we have caseworkers who are non-clinicians, but provide services to those individuals. And they really focus strictly on, their physical conditions and, their financial, perhaps, as it relates to housing and housing, anti-eviction initiatives. So, I think that we have very little expertise in handling and dealing with people's mental health conditions. And I think this is what, the Harlem Strong Initiative is designed to fill that gap. Because we're not going to become clinicians. That's not the role we're going to play, but we're going to play the role of navigating people to the right resources, perhaps being that voice to explain that you don't have to feel stigmatized and you don't have to feel disconnected, but we'll get you culturally sensitive mental health care, the care that you need that will best address your conditions. And I think that's something that is very important because, in order to overcome that barrier, that 86%, perception or feeling, real feelings that are disconnected, you really have to have trusted supporters and navigators. And we think that the houses of worship are probably the trusted navigators in our community. We think that, community health workers and case managers who built a relationship with, our consumers over an extended period of time became those trusted advocates. And with that foundation, we could steer people in the right directions through their managed care, systems, as well as our clinicians, and then to our clinicians, because you can't make that jump right to the clinicians. No one in the Black community is gonna allow that, subject themselves to that fear and that condition, because there's too many examples of abuses in healthcare and systems, and lack of value placed on, to borrow Dr. Bean's example, the lack of value placed on our lives, not just our mental health conditions, just the very existence of being has been undervalued or in many cases outright eliminated. So it's just not possible. So we really have to take it in steps, and initiatives and building trust, because in many ways, African American community, Dr. No, in many ways, the African American community are refugees in their own country. That's just been our legacy. So in order to overcome that, I think, having trusted advisors and advocates is very important.
May I add a little bit to that? Because for the reasons that Dr. Punter mentioned, as we've been dipping our toe into the deep end of the pool in terms of working with community-based organizations to see how we can support them in the kind of work that he described, what we have discovered is we have to support the relationship between a health worker and an engaged person over time. And we also have to support our practices over time. And the time factor that Dr. No and others talked about is really shifting everyone's trust, everyone's level of trust over time. And I think, it will build on itself, reach a tipping point, and then this model will become part of what we do. One of the resources that we hope to add to Dr. Punter's team as they navigate alongside both the residents and their health centers will be a way to find specialists, to find the care needed. And there are some access points that we can provide that are not limited to Healthfirst members. Because if we don't do that, then we lose the equity value here. So we are going to provide some ways for the workers to find the mental health and other services that, when all put to, it's hard for you not to be depressed if you have diabetes. So you may need an endocrinologist. So, the specialist is able to sort of navigate themselves with a little bit more ease. We would sort of bringing value to the community in every way that we frankly can think of. I think Dr. Punter, Dr. No, and Deborah would agree.
Thank you, Dr. Bean, for that. And thank you, Dr. Punter, for bringing in sort of the historic perspective. We have about 9-10 minutes left. And I'd like to, again, encourage folks in the audience to send in questions if you have any.
I have a question for our participants. So may I ask it?
Please.
So are any of our participants actually involved in one way or another with the mental health service community? And if so, what are your thoughts about this initiative or primary care, attempting to bring either of those services to residents of communities like Harlem? You can just put it in chat or however best we can hear from you a little bit. What's your feedback to us?
Have everybody been introduced to each other?
We have a quiet crew this week.
I'm not sure. I think folks can unmute themselves. I'm not 100% sure.
I'm looking to see if there are any hand raised.
Yeah, we were unable to.
I'm going to call on one of my colleagues who
Please.
is inspirational to me, Donna Taylor. I see you. And you've been an advocate for this kind of help for your whole career. Do you mind just saying a couple words? You can thank me later.
Yeah, and I was gonna say, unfortunately, I was late and I missed most of the presentation and just came in on the back end. So, but I would like to hear the recording. I have it marked in my calendar so that I can weigh in. I always think community work is super important. I think it's a great community for us to be, supporting, but I really can't provide any intelligent or meaningful feedback. I apologize. I'd like to be able to.
That's all right. I think the question really that we're thinking about now, Donna, is how to, in communities, how do we consider, we learned that 86% of the community feels they have no access to mental health.
Mm-hmm.
And I know that you spend a lot of time at Healthfirst working on access to behavioral health and mental health services. Just wondering if, and it doesn't have to be anything special, but just in general, how tough is that challenge?
It's actually really, it's difficult. We had 2 Healthfirst members at an advisory board yesterday who really identified a couple of things for us. One is language. And for both of those members who access mental health services, they saw a lot of recovery language in our literature and said, well, to me, recovery means recovering from substance use disorders. And I don't associate that with mental health conditions and recovery and mental health. And it's off-putting and it's sending a different message, which I thought was interesting and important for us to really think about. The fact that primary care is not a reliable referral resource or a place where they feel safe having those conversations. Both of our members shared that information as well. That materials aren't well targeted, and we do offer, particularly for people who are living with serious mental illness, some of our plans offer access to a lot of wraparound services, and we've looked at a lot of different ways to market them, both through mailings, through Healthfirst, care management linkages, through work in the communities, and that is not resonating. And they really talked a lot about the importance of, what do I want to call it? Direct referrals, peer-to-peer referrals in the community. So hearing from other members of their community where's a safe place to go, and what services are out there. So I mean, those were some of the takeaways from yesterday. But again, this getting back to language and how powerful it is and how off-putting it can be, and really how difficult it is to navigate the system, whether you're an individual, whether you're a parent, whether you're an adolescent. And the issues are very different, and there's really no one-size-fits-all approach, because the community cultures are so different, right? Every community has sort of a different way of being in the world, and really needing to understand that when we go in and think about how to open the doors to treatment. Was that helpful?
Mm-hmm.
Okay.
Fabulous. I think, Ms. Stokely, did you have a question or a statement?
Oh, no, I didn't. I saw that you asked me to unmute. I'm just glad to be here as part of the community. So thank you so much.
Thank you.
We do have a comment in the chat from Miss Carmen Jones. Miss Jones, I'd like to invite you to unmute if you'd like to, or if not, I'll read the comment. I'm not sure if Miss Jones is able to unmute, so her comment says mental health assessments in primary care tend to be simple questionnaires with poor follow-up. So I'm glad this project is breaking down the problem and addressing the issue. Thank you, Ms. Jones, for sharing. We appreciate your feedback. And same for you, Ms. Taylor and Ms. Stokely. I have a couple minutes left if we have any other comments or questions, or if not, we can wrap up.
So I just want to remind folks that part 2 will be December 7th. We'll be sending out at the end of this the recording. Please share this with others. Our ask is super simple, which is think about the block associations, the coalitions, the advocates, the navigators, community-based organizations who maybe don't focus on mental health, but are seeing community members who are struggling, to our executive directors who have staff who may need the continued support. We are happy to bring you into the coalition. I just want to remind folks that there is no fee attached to this. This is really around supporting the community and really building out what we know is critical and important. I do want to leave space for Dr. Bean or Dr. Punter or Dr. No for any closing thoughts. And also, yes, I just saw in the chat, we also would love participation from the local schools as a part of this process. No one is left out from our continuum of community care, in the words of Bishop Washington, founder of HCCI, whomsoever the doors are open, we want one and all to be at the table. Dr. No, Dr. Bean, Dr. Punter, closing thoughts?
Just want to thank everyone for being here, and want to thank all the other, panelists, Dr. Bean, Dr. Punter, you, Deborah, for, bringing us together and for making this possible. This is such an exciting project, and I'm so proud to be part of it.
Yeah, I echo the gratitude. I think, in order for us to do this work in a meaningful and impactful way, we need the participation of the community in its various forms, and we welcome your feedback. So please don't hesitate to contact us post this discussion with any thoughts that you may have.
And just a simple thank you from me, from Healthfirst. Just thank you for allowing us to be part of the coalition. We're grateful. Thank you.
Appreciate you all. Thank you to the teams of HCCI, Healthfirst, our school. There's lots of folks in the background who make all of this happen. And so I just want to acknowledge them, but most of all, I would like to acknowledge our community participants who will continue to give of their time, their energy, and their talents. Thank you all. There will be a closing quick survey because of course it wouldn't be an academic institution if we didn't have an evaluation. So please tolerate us and do this quick poll for us so that we can stay in compliance. And again, you will continue to see, we will be presenting at community boards 9, 10, and 11, keeping this information current. We're looking forward to starting the coalition in February and your referrals. But thank you one and all, and please look forward to getting the link in the next few days. Thank you, everyone.
Thank
Appreciate
you.
your time, your energy, and your talents. For those, happy holidays. For those that will be engaging, please also remember to be safe and wear your mask.
Bye. Thank you.
Thank you, everyone.